Before starting my talk, I just wanted to quickly mention my talk today is more educational because I know there's a lot of people from industry, different stakeholders, and I want to give some key take-home message which can be applied to their regular day-to-day work. So let's get started. So when we think about recovery after spinal cord injury, our mind often goes straight to mobility, independence, and physical rehabilitation, which we have clearly heard in previous talks as well. Yet there is another side of the story, one that is less visible and equally critical: the cognitive health and psychosocial resilience. So many people living with spinal cord injury experience changes to their mental well-being. These changes can significantly impact their quality of life, social participation, and ability to manage their health. So in this talk, I want to take you beyond and across the injury, looking at people across the spectrum of injury, from mild to severe, and across the continuum of care, that is from acute rehabilitation to long-term community care or support, in my next few slides. So I will explain briefly what we know about cognitive health and resilience, what recent research is teaching us, what we are doing, and what might go next, or what we will continue to do next. So if I just quickly, before going into the topic, quickly give you like an understanding on, for the people in the room who might not have understanding on that two key terminologies I'm using on this slide about cognitive health and psychosocial resilience. Let me start by saying that cognitive process are the procedures we use to incorporate new knowledge and make decisions based on our said knowledge. And that cognitive process can happen naturally or artificially, consciously or unconsciously, but usually happens fast. So people with spinal cord injury commonly experience these changes in attention, memory, and executive functions, skills which are very, very essentials for daily planning, problem solving, and daily decision making. On the other hand, resilience is the ability to adapt and maintain well-being despite the challenge of injury. So protective factors include strong social support, effective coping strategies, and engagement in meaningful activities. Resilience is very closely linked to the cognitive health. Those with high resilience tend to maintain better cognitive function and overall quality of life. So if we take them together, we see that cognitive health and resilience are interconnected and both play a critical role in supporting people with spinal cord injury to participate fully in life, manage their health, and maintain well-being. So in other words, resilience supports the network that can buffer the impact of cognitive decline, helping maintain a high quality of life despite impairments. Moving on, while there is a good understanding of common cognitive changes and resilience factor, recent research provide evidence on how these factors evolve and how we support people more efficiently. So cognitive trajectories over time, some of our longitudinal studies that we have been undertaking for multiple years shown that cognitive function can change across the lifespan after spinal cord injury. Some people remain stable, and while others experience gradual decline, often linked to secondary health condition or aging. Emerging interventions, which are more around that early intervention or evidence, support that intervention like cognitive training, mindfulness and resilience building program, digital health tools, telehealth and structured self-management approach are showing promising effectiveness in maintaining and improving cognitive and psychological outcomes. Integration with that everyday life, we are learning that intervention that are more effective, that are embedded in our daily routine, personalized to individual needs, and considering social and environmental factor. And lastly, we have to keep the person with lived experience at the center of this in co-designing, developing intervention that ensures there is relevance, usability, and uptake. So in the existing literature, and this particular slide is more focused from the data which we have produced over the year in spinal cord injury space, that occurrence rate of cognitive impairment following spinal cord injury varies from like 10 to 60%, which was invisible and can undermine the outcome of SCI rehabilitation. But in our recent ongoing longitudinal inception cohort study, which has just concluded last year, we estimated that occurrence rate of cognitive impairment after spinal cord injury in our cohort at acute phase, 3 months post-injury and 12 months, was around 25%. Sorry, there was a typo, like not on this slide, sorry. 25%, 22%, and 16% respectively. So what is the evidence? So as you can see, and like on the very top, that's our foundational paper, which I think Ashley has done in 2007. And we have been understanding the concept of cognition after spinal cord injury over the years. And there is more work to do, more work is coming, more work is under publication. And I just like presented this slide that there is a lot of evidence around this area now, and it's a very upcoming area in spinal cord injury stream. And just like to add on, you will be provided with all the slides, all the recording, even the some of the key references which are presented today in the whole package post-conference. So you don't have to take any pictures, but you're very welcome if you want to. So now, my next few slides are more focused on that theoretical model which we have learned over the years doing that cognitive research, specifically in people with spinal cord injury. And I think like on this slide, I would just like to reiterate, and I want to just reinforce and re-emphasize, sorry, that's the right word. English is not my first language, so I can be excused. It is essential to recognize that cognitive impairment is also prevalent amongst people with spinal cord injury. Cognitive deficits can significantly affect person's daily life. Understanding the rates and nature of cognitive impairment, healthcare professionals can tailor programs more effectively, recognizing and managing cognitive issues that can lead to improved psychological well-being and reduced stress, and ultimately to a higher degree of independence in their life. So the theoretical framework employed in this model today draws from the principle of neurorehabilitation, neuropsychology, and neurobiology. It applies these concepts to a specific context of SCI-related cognitive impairment. Before going into discussing the model, I would like to emphasize on one important aspect that potentially contributes to cognitive impairment is that pre-morbid history and possibly have led to maybe initial spinal cord injury. I know there is a lot of psychologists in the room, so I want to make them happy that I'm not ignoring the pre-morbid conditions. I'm not a psychologist, but I'm just trying my best. Okay. As I said, it's important factor from pre to post, one of the important factor in assessing that. So this is the theoretical model that I would like to propose with these 5 contributors, and I would like to discuss them in my subsequent slide. And as I said, you will get these slides. If I go like quicker, please excuse me, just mindful of time. So let's go into the very first factor that involves the inflammatory change to the central nervous system, and which in itself, as you can see from the diagram, and I'm not like anticipating that we all understand this complex phenomena, but to make it simple, when there is an injury to the cord, which you can see on the very left of the slide, it leads to the primary and secondary inflammation of the central nervous system, which includes spinal cord and brain, eventually leading to that neuroinflammation, as you can see on the right side of the slide, and then causing that cognitive impairment. So that's one cause. Then there is also like another cause we talk about in our model, which is about also impaired autonomic nervous system. And I'm not going into that much detail because I think Professor Craig has mentioned a fair bit like in his talk this morning. Okay, then moving to the secondary, the second contributor is more around personal factors. There are a few personal factors. This is like my, I think, slide 1 of my personal factor. As you can see, Age, gender, and educational status are some of the contributor to cognitive impairment. And for example, if I just like mention about educational status, we know that people with poor pre-morbid academic performance were more likely to have a cognitive impairment. Some of the other personal factors are about like that physical inactivity, which can also contribute to cognitive impairment through mechanism including reduced blood flow to the brain, decreased neurogenesis, and impaired synaptic plasticity, leading to complex cognitive function. And I'm sorry I use like a lot of jargon there, but in a nutshell, I'm just like saying if you're not physically active, it might contribute to cognitive impairment post-injury. Then alcohol and drug abuse, of course, affect attention, memory, planning behavior, and decision making. And then moving to our next contributor, which is like more, when I say like from the continuum of care, it's more we see in that acute phase of the injury when people have that prolonged or intensive hospitalization, especially that longer stay in like ICUs following SCI, which can disrupt their familiar environment cues and routines, potentially leading to confusion and stress. This may like adversely affect that cognition, and then also like that, like transitioning from that hospital and community poses a significant challenge. And we know from our research in that period when people are transitioning from hospital to community, the anxiety level goes high, which is also like one of the common contributing factor to that their cognitive function. Then we have a third factor, which is more around like the secondary health conditions. And as you can see, I have listed a few of them, and we all know. And when we were like doing this research, we understand that most of the time in ED, when people are approaching EDs, the only time a cognitive assessment was done when there is a factor of TBI associated, and which was like for us a good way of teaching like ED staff that it's not just one cause, it can be multifactorial, and we have to look for everyone and screen everyone in that space. Then some other factors like chronic pain, which can also result in structural and functional changes to the cortical region, which can then be associated indirectly with learning, memory, fear, and emotional responses. And one other important factor is also like chronic fatigue, as you can see I've listed on the slide. Then there are some other secondary conditions. Craig and colleagues found that depression and anxiety, as I mentioned previously, may negatively impact cognition. Interestingly, this study they have undertaken, like I think in 2017, also found that the mood disorder may be consequence of cognitive dysfunction instead of cause of cognitive dysfunction. And then there are other medical causes which are listed on the slide. I'm not going into that much detail, but we will provide you more evidence on that. And I think the last factor is more around that polypharmacy. And we know some of the medications like opioids, anticholinergics, and baclofen, they are like some of the common medications that people with spinal cord injury use. For example, baclofen for managing spasticity, which also have like a well-recognized side effect. And we know that baclofen has shown its detrimental effect on memory and learning in people with known cognitive dysfunction. And lastly, there is antipsychotic drugs, which can also be related to hospitalized patients with SCI who develop delirium and for sleep. So this is my concluding slide. So having explored what we know, what we are learning, where do we go next to better understand cognitive health and psychological resilience after SCI, that early detection, which we are working on developing a tool and screening method to detect that cognitive change early, so interventions can be timely and personalized. That integrated intervention, which is about embedding cognitive support, self-management strategies in standard rehabilitation and ongoing care as a part of our ongoing implementation research, which I think is led by Professor Craig and like my colleague, Dr. Candice McBain. Then aging focus approach, tailoring intervention to the unique needs of people aging with SCI, recognizing that risk and protective factor change over time. And lastly, that technology-enabled support, which again goes back to like Scott's comment this morning, that leveraging that artificial intelligence, telehealth, digital marketing, monitoring, cognitive training apps to extend that support beyond the clinic to homes for people with spinal cord injury, providing a strong ecological validity. All by involving, putting people with lived experience. As I said, we need to put them in place for that usability and context, and then across discipline, rehabilitation, psychology, neurology, and community service to ensure that we are producing relevant, relevant products, uptake, and their sustainability. Looking forward and acting across the spectrum of injury, the continuum of care, we can create intervention that help people with SCI not just manage their condition, but thrive cognitively and psychologically throughout their lives. So lastly, I would like to just thank my team listed there, and a special thanks to iCare for funding this amazing work, what we have done, self-patting, amazing work, over many years. So, and I think we are very proud what we are doing and what we are producing. So thank you.